All right, good morning, everyone. It looks like today was a dementia day because Dr. Nocturna presented the vascular dementia, and I'm going to its Alzheimer's disease. So my name is Dr. Sahil Kapoor. I'm from JJ Medical College in India, and I'll be going forward presenting Alzheimer's disease today. The first thing that I would go is the history. A 74-year-old male patient came with his wife. He complains of memory issues that began a few years ago as he started forgetting names of his children and getting lost in the neighborhood, entering houses of the neighbors as well. They slowly progressed, and the family members were getting scared. And they're worried because he's a little aggressive and has irritable mood. They believe that he's not himself and has been secluding himself. And over the past few months, he started developing urinary incontinence as well. His past medical history is type 2 diabetes mellitus since 20 years and hypertension 25 years. He has no history of falls or seizures. His family history, both his mother and father had diabetes and hypertension. On physical examination, the patient looked expressionless, mildly sundowned, and he had the stated age and was groomed well. He also had small rashes on the body, which was probably due to the aging. And he had weakness as well, which was generalized. His gait was a little slow. We did the Beck's depression inventory, which was inconclusive. On neurological exam, he had various neurocognitive deficits associated with emotional distress. The patient frequently complained that he had developed difficulty remembering things. And on physical examination, he was stable, well composed, and actively conversant. He also became a little anxious and a little frustrated as we went ahead with the physical examination. His MMSE score was 20 out of 30. Now I'll go towards the past, what we know so far in the field of Alzheimer's disease, how it started, and where we are today. In 1906, Dr. Alzheimer was the first who saw a patient named Miss Dieter in a local asylum who had strange behaviors. He followed her closely to her death at the age of 51 and examined her brain tissue on autopsy. He noted there were some plaques and tangles, but he couldn't figure out what exactly they were. In 1911, they did the research again as the base by Dr. Alzheimer and that came to a diagnosis of Alzheimer's disease. But in 1990, it was figured out that the main thing that was getting accumulated was beta amyloid protein. So it took about 90 years approximately to figure out what exactly was causing it. It is the most common cause of dementia in people over the age of 65. 10% of people over the age of 65 and 50% of people over the age of 85 suffer from this. Approximately 4 million people in the United States regularly suffer from it, and the annual treatment costs are about $100 billion. It is the fourth leading cause of death in the United States, and the overwhelming majority of patients live at home and are cared for by the family and friends. As we see the projection of this disease, we see that in 2010, there were only 4.7 million people suffering from it. But by 2050, it will be 3 times, around 13.8 million people suffering from this disease. Now I'll discuss about some risk factors. There are some modifiable risk factors and the non-modifiable risk factors. The genetics, ApoE2 is preventative, whereas ApoE4 causes this disease. And the protective risk factors as compared to diet, like Mediterranean, exercise, moderate alcohol, and even education helps preventing this disease. Whereas the causative factors can be hypertension, diabetes, obesity, hypercholesterolemia, and smoking. When we see the history and the pathophysiology and pathology of this disease, we have 5 different mechanisms that contribute to it. I'll go over each one of them briefly. The first one is the amyloid cascade hypothesis, which states that APP, PSEN genes, and other risk factors around the environment, they contribute together and they perturb this normal cellular homeostasis, leading to formation with tau plaques, cell death, and further dementia. This is the most prominent theory that is prevalent in most of the hospitals, and doctors follow it mostly. The second is the neuronal loss theory, which they state that as the aging progresses, there is diffuse atrophy and widening of the sulci, enlargement of the ventricles, progressive loss of the neurons, and their glial cells, and thus mostly prominent in the hippocampal and the basal forebrain region. The third is the acetylcholine hypothesis, which states that the loss of acetylcholine, other noradrenaline, serotonin, GABA, they all have been documented in this. But mostly it's prominently the acetylcholine, which is in the basal forebrain and the locus coeruleus of the main region is the locus coeruleus of that part. The fourth is the excessive excitotoxicity, which states that excessive glutamate release in the synapses leads to excessive influx into the cells, and causes cell death, which leads to the formation of A beta and tau phosphorylation and further oxidative damage. And the fifth and the last one is the genetic factors, which are the presenilin 1, 2, amyloid beta precursor protein, and apolipoprotein EG. All of these factors come together and cause devastating effects in the brain, leading to extremely severe Alzheimer's disease. What are the signs and symptoms? As the Alzheimer's disease starts, we start with a little bit forgetfulness, difficulty finding certain words that a person already knew, a little bit of apathy, mildly depression because he's trying to figure out what's wrong with him, which progresses further to confusion, insomnia, also speech difficulty and restlessness. And when it goes to the severe phase, it is progressed by the 4 A's: agnosia, apraxia, aggression, agitation, followed by gait disturbance, and incontinence. So how do we assess a patient with it? First, we take a history, not only from the patient, but also from the relative or other people, those who care for the patient. And we take a comprehensive physical and the neurological examination. We go with a cognitive evaluation with minimal mental state examination, a clock drawing test, or a MoCA, which is considered as most sensitive test. We check the basic functioning status, if a person can live alone or not, if he needs assisted living facilities or not. Then we go towards the lab work, which is by the CBSE, his vitamins, his thyroid, and all the CSF markers, which could be considered as well. And also the imaging, in which we see if there is destruction in the brain and what segment is involved to what extent. These are the scales, the mini mental state examination, in which we have the different scoring criteria. 29 to 30 is considered as normal. The second is the MoCA, which is the most sensitive test, and in which they did a study and figured out that 23.27 is considered, below that is considered as the normal control group, above that is considered normal control group, and 11.97 and below is considered as the severe Alzheimer's disease group. What is the treatment of this disease? There are different treatment criteria followed by different physicians. They always start with the acetylcholinesterase inhibitors like the donepezil, rivastigmine. But when it progresses further to moderate and severe disease, they give imantin in them, which is the NMDA receptor antagonist. There are different dosing patterns, and each one has their preference, and according to the body weight, also some people follow. Now, this question is, why is early treatment beneficial in it? How can we kind of, if not prevent, but delay it? As you can see from the graph, the amyloid beta is the first thing that starts accumulating in it. And if we can target it and prevent it, we can probably delay the disease, if not prevent. What are the advancements in the field of Alzheimer's disease now? There are a number of research going on. They all target the beta amyloid protein. Some target the vaccines. Some are the beta secretase inhibitor ones. There is also a natural component in which they study the curcumin or the turmeric effects in preventing aging or Alzheimer's disease. There's another one in which they target the different acetylcholine receptors, serotonin receptors, also the kinase inhibitors. Now I'll move towards the newer development, which was recently launched, the aducanumab in the Alzheimer's world. What is it? It's a monoclonal antibody that works in the early stages of Alzheimer's disease against the amyloid beta tangles. We have to be very sure about it that it does not prevent it, it only delays the progression of disease, and it helps in slowing the memory and general cognition deficits. What are the side effects? Whenever we look at a patient who's undergoing a treatment, there are certain amyloid-related imaging abnormalities observed, which can be due to the swelling of the brain or the bleeding. Some people also experience falls, dementia, and disorientation. And what are the problems? When we take a look at the scenario, we say that it needs multiple injections. And some people, they become non-compliant with the injection trials and they cannot complete it. It's also a highly costly drug, which is around $56,000 a year. Not every people can afford it until the insurance comes forward, and there are various plans that would cover it to a certain level. And there are also very limited number of trials. That's why many physicians are still hesitant to introduce it into their clinical practice. So as we can see in this, how it works and what it does. So on the clinical trials, it was observed that a patient who came with Alzheimer's disease had this red segmented plaque accumulation, which improved further in 1 year to this. So it wasn't preventing it, it was just delaying the progression towards the severity. The next is if we should continue it or not. So if a patient who is undergoing a trial or who's undergoing a drug administration, if he comes to you and he has symptomatic disease or he has symptomatic falls or anything that we could see on a brain imaging, we have to discontinue the treatment at the same point. But if he's asymptomatic and he still has mild changes with respect to hemorrhage or edema, we can continue the treatment until his course. So that was the first drug. Now I'll talk about the second drug that would be potential a game changer in the field of Alzheimer's disease, which is the Galimedex, GAL101. So since aducanumab works later in the disease development when they have already formed or they have already accumulated, Galimedex prevents the misfolding in the early stages, which could be potentially the best drug that could come out in the near future. The trials are still undergoing, and hopefully we could see a potential date soon. So the last segment I would like to talk about what we do, me working at the University of North Carolina in Deshmukh lab in the field of Alzheimer's disease. So we focus on microRNAs. MicroRNAs are the mini microRNAs, the pre-segmented RNAs that are involved in various genetic processes. They are involved in various diseases, also in tumors, cancers, and recently they have started getting involved with Alzheimer's disease as well. So what we did is we found out that the mature brain has very high levels in a normal individual, have a very high levels of MAGE29. But on the contrary part, when we examined them at the initial stage of development, they had very minimal levels, almost none. And also in the Alzheimer's disease patient, we saw that the levels were greatly reduced. So we thought that if something is elevated in a normal individual, it must play a role in the integrity of the brain. So taking that hypothesis from it, we generated two mouse models. In the first model, we kind of decreased the MAGE29 levels in them conditionally. And in the second one, we kind of increased the MAGE29 levels on our level, like we could stimulate it towards that. So when we started doing that, we saw that when MAGE29 is present at 0 level, or if it's not present at all, the mice died within a month. And when we expressed it over continuously as soon as they were born, they also experienced aging effects, like they had all the teeth were broken, they were hunched, and they had loss of hair. So we started linking that data to Alzheimer's disease because we kind of compared the already available data, and we are crossing them with the mice models that are with the tau protein or the APP-PSEN1 models so that we could come up with a new therapeutic mechanism. As we all know, that microRNAs or RNAs are the newer medicine trends in the world, also in the COVID scenario. So hopefully we can link that to one of those mechanisms and come out with a newer version of vaccine trials. So I would like to show some images that we saw. So as you can see, this mice was extremely normal. This is a wild type mice, nothing happened to it. But when we expressed MAGE29 in it extremely, it underwent aging within 2 months of age. And on dissection, you can see it's extremely disheveled. The organs were completely small. And also it had a hunched, as you can see, the scoliosis developed in them. So we are trying to see if we could, come up with something new. And I think these are my references. And I would like to end by a few lines that I wrote for my grandfather since he suffered from Alzheimer's disease. I saw him running, dancing, and playing with me every single game. I saw him happy, smiling in every frame. I saw him forgetting mine and everyone's name. And then without him, it was never the same. So let's take a step further towards the Alzheimer-free world. Thank you. Any questions?